This presentation is titled Pediatric Considerations for Post-Acute COVID-19 Management. This presentation is within a series called the PACER Project, presented by the Cardiovascular and Pulmonary section of the APTA. Before we get started, I'll tell you a little bit about myself. My name is Ashley Parish, and I'm a board-certified cardiovascular and pulmonary clinical specialist with a focus on pediatrics. Prior to becoming a physical therapist, I was actually a respiratory therapist. Currently, I'm an assistant professor at UAB in the Department of Physical Therapy, and I have no disclosures. As a disclaimer, this course was intended for educational purposes. We know that COVID-19 and information surrounding it is currently changing every day. So at the time of dissemination, this is the most current evidence that we have. For the objectives of this course, first and foremost, we want to discuss the COVID-19 pediatric statistics. We'll look at things like male-female ratio, severity of cases, and common signs and symptoms. We'll talk about the potential implications on the cardiovascular and pulmonary system post-COVID-19. We'll throw it back and talk about the development of lung structures throughout the pediatric lifespan. And then we'll utilize our evidence-based practice to assess CVMP outcomes and talk about appropriate interventions in this population post-COVID-19. So let's start this off by discussing pediatric COVID statistics and data. We'll take a look at what we have from China, Italy, and the USA. So before we start, let's define pediatric. For the purpose of this presentation, it will be defined as someone who's 18 years or younger. So the first data we really gathered from China was the study that showed that 2,143 pediatric cases were reported between the dates of January 16th and February 8th. Which is a 3-week span. Of these, only 731 were lab confirmed. The rest were suspected due to being in close proximity to an adult that had COVID-19 or showing minimal symptoms and didn't want to get tested. The median age was around 7 years old, which is lower on our lifespan range. 56.6% were male and 43.4% were female, showing that there really wasn't a gender difference in who gets COVID-19. The most staggering thing we learned from the study was that 90% of these cases were asymptomatic, mild, or moderate. We'll break this down on the next slide, but it's kind of hard to predict if COVID-19 will have an impactful function on somebody who is asymptomatic versus someone who is critical, mechanically intubated, and developed pneumonia and ARDS. There was one death that was reported in February of a 14-year-old. Circumstances were not reported. There's also a reported death of an infant in March of 2020. So this 10-month-old died of intussusception, which is where an infection can tear holes in the intestines and they can actually slide into each other. This is a medical emergency as it can block food, fluid, and blood flow. This 10-month-old also developed multi-organ failure due to COVID-19, and they were hospitalized for about 4 weeks before they passed away. So on this slide, we see how China defined the signs and symptoms of COVID-19. In the blue is what 90% of pediatric cases were defined as. Asymptomatic, so there were no signs and symptoms. Chest imaging was normal, but they were positive on the COVID-19 test. Mild, we might have had some signs and symptoms of an upper respiratory infection, which is common around the winter time for pediatric patients. So things like fever, fatigue, aches, cough, sore throat, runny nose, and sneezing. When we get to the moderate category, this is when we start to see some hospitalizations. So these patients might have pneumonia, a fever, dry cough. They might have some wheezing, but they don't show the signs and symptoms of hypoxemia. When we get to the severe and critical cases, these are hospitalized, and they can be on mechanical ventilation or ECMO or other types of life-supporting devices. So with severe cases, we see fever, cough, GI symptoms, most commonly diarrhea, and we'll talk about why later in this presentation. Dyspnea with central cyanosis, so we might see some blue around the patient's lips, which is most common in pediatrics, and we might see O2 sats below 92%. With critical cases, we start to see things like ARDS, acute respiratory distress syndrome, septic shock. We see heart damage, which is becoming more prevalent in COVID-19, so left ventricular function is impaired, acute kidney injury, and we see a lot of multi-system organ failure. What's fascinating about the data that came out of China is the breakdown of critical cases by age. If we take a look at this chart, we can see that most of the critical cases are children who are less than 1 year old. As PTs and PTAs, this is fascinating because we really don't know how COVID-19 is going to impact our developmental skills, our cognitive skills, and we don't know if someone less than 1 year old who is critical is going to look different than a 16-year-old who is critical. So we've all heard that children aren't impacted by COVID-19 like adults. So why exactly are there fewer pediatric cases? It's all about the ACE2, and us cardiopulmonary people love some ACE2. It stands for angiotensin converting enzyme, and it's found throughout the body, specifically the lungs. Also found in the GI system, which might account for diarrhea in COVID-19 patients. The function of ACE2 is to lower inflammation in the body and also lower our blood pressure. It's thought that the maturity and function of ACE2, specifically the binding ability, might be lower in children versus adults. So it's not giving the virus that vector to get into the body and reproduce. Children also experience respiratory infections in the wintertime. Hello, RSV. So they might have higher levels of antibodies against viruses than adults do. And furthermore, their immune system is still developing and might respond differently to pathogens. Then we have to think of things like world travel and human interactions. Children aren't hopping on jets, hopping on public transportation and going to work every day. They don't have that environmental exposure to people, to pollutants, to allergens. And this is something we saw when we had the SARS outbreak and the MERS outbreak in 2002-2003. Childhood cases weren't as vastly reported as adult cases, and they weren't impacted as much as adults. With that being said, it's actually suspected that children are equally susceptible when compared to adults, but they're less likely to be exposed to the virus due to what we just talked about, and they're less likely to be tested due to asymptomatic or mild symptoms. This is of concern as the number of infected adults increases and the need to be around their children. It is hypothesized that the asymptomatic children could actually be the main spreader of the disease, and we need to take this into account when schools and daycares open back up. So how exactly is this disease transmitted to children? The data we have from China shows that most pediatric cases come from family clusters where there are infected adults. There's no evidence of intrauterine infection caused by that vertical transmission from a pregnant lady to her fetus. There's also no evidence that the disease is passed through breastfeeding or breast milk. From China, we saw that the youngest infected child was 30 hours old after birth, but it's thought that this transmission occurred through close contact with the infected mother after birth. There is a risk for potential transmission through the fecal-oral route, as COVID-19 has been found in stool samples anywhere from 17 days to 30 days after diagnosis. This is a process called viral shedding, where the body tries to get rid of a virus. This has implications for us and parents as we change diapers, as we send children to daycare where feces can get transmitted easily. So wash your hands. So to summarize what we learned from China, children at all ages are susceptible to COVID-19. There's no significant gender differences. The manifestations are less severe compared to adults, so we see more asymptomatic, mild, or moderate cases in children. The infant age group is the most vulnerable to these critical or severe cases, and pediatric deaths are possible from it. There's no evidence that shows that COVID-19 is transmitted through a pregnant mother or breast milk, but there might be a fecal-oral route of transmission. So what do we know about pediatric cases in Italy and the USA? To date, Italy's reported about 1.2% of their cases to be pediatrics, with no deaths. USA has reported 2% of their cases as pediatrics. Most of these have an underlying cardiovascular or pulmonary disease. Of these cases, 15% were infants. When we take a look at that and break it down, infants actually make up 40% of the pediatric hospitalizations and 33% of hospital admissions. USA has 3 confirmed pediatric deaths, but it's also speculated that this number is about 7 currently. So now let's take a look at the sequelae of COVID-19. We'll talk about things like pneumonia, ARDS, septic shock, and hospital-acquired weakness that we'll see in these moderate to critical cases. Pediatric pneumonia is actually one of the greatest causes for morbidity and mortality in children. Pneumonia occurs when an infection causes our alveoli of the lungs to fill with fluid or pus. It makes it really difficult for enough oxygen to get to our bloodstream and travel around our body. If pneumonia occurs during critical developmental periods of our lungs, which we'll talk about next, it can adversely affect the structure and function. It also puts you at higher risk for subsequent chronic lung disease. Those who are actually hospitalized with pneumonia have a higher chances of getting sequelae later in life. So we see things like restrictive lung function, and I always tell my students to think of Chris Farley in Fat Guy in a Little Coat. You can't take a good breath in with a restrictive lung dysfunction. Or obstructive, we can't get a good breath out. Some categories that fall under these two are asthma, bronchiectasis, and COPD, which occur in adulthood after pneumonia. With COVID-19, we're seeing pneumonia most frequently in the right lower lobe and inducing a right upper lobe atelectasis. So let's chat about pediatric acute respiratory distress syndrome, or ARDS. It's one of my favorite diagnoses. It's fascinating to me. It's caused by an infection or trauma that causes leaking of fluid into the lungs. It's diagnosed by an acute onset, so these patients get it quickly and they go downhill quickly. There's bilateral infiltrates in their chest x-ray, so I get a lot of questions about the difference between pneumonia and ARDS. Pathophysiologically, they're completely different. And on the chest x-ray, you'll always see ARDS be bilateral in nature, both lungs impacted, whereas pneumonia, only one lung or one lobe might be impacted. With ARDS, there's a PaO2-FiO2 ratio of less than 200, so the partial pressure of oxygen in the body to how much oxygen we're on. These patients also have a fever and leukocytosis. 8% of patients who are mechanically ventilated develop ARDS. So this is kind of a chicken and egg situation with COVID-19. So if a patient with COVID-19 is on the ventilator and develop ARDS, was it mechanical ventilation that caused it or the disorder? Okay. Mechanical ventilation can cause ARDS pretty easily through the use of high PEEP levels. So if you think about blowing up a balloon constantly, and at the very end of your breath, you give a really hard breath to blow the balloon up. If you keep doing that, eventually you're going to stretch the walls of the balloon and cause it to break down. And this is kind of the thought process behind ARDS. ARDS has a really high mortality rate, about 18 to 35%. We see a lower mortality rate if we prone these patients. I can't say enough about proning. And when we prone in ARDS, we don't prone for a couple hours. We want to prone for at least 12 to 18 hours to help with our VQ mismatch. Patients who survive ARDS are discharged with neuromuscular weakness, nutritional deficits, and persistent pulmonary dysfunction, and this continues all the way into adulthood. It's important to know that these patients are also at high risk for developing PICS, which is post-intensive care syndrome, which there's another series in this webinar that discusses PICS in details. What's staggering is that the persistent and profound oxygenation and ventilation deficits that are seen all the way into adulthood. We'll see everything from inflammation to coagulation dysregulation and pulmonary fibrosis. So our lungs get really stiff and hard and they lose their compliance later in life. There are a lot of articles out there that look at pediatric lung function post-ARDS. I wanted to highlight one of them that looked at pulmonary function and quality of life scores. So this one particular study showed that 1/3 of children with ARDS exhibited pulmonary function deficits and quality of life scores lower than children with chronic asthma. The quality of life scores looked at things like general health, physical functioning, the emotional, social limitations, and mental health aspects. They also examined pulmonary function as an infant right after a course of ARDS, and this can be tested via face mask and nitrogen washout technique. So they put a little plastic vest called a baby hugger around a baby, and you can rapidly inflate this vest, and you can obtain expiratory flow volume loops from it. You can also look at airway reactivity. So what they really found was that post-ARDS data was similar to those with adults post-ARDS in terms of pulmonary function and quality of life. So septic shock occurs when an organ is injured or damaged due to an infection. This leads to dangerously low blood pressures and abnormal cellular metabolism. Septic shock is treated with inotropes and vasoconstrictive agents, as well as mechanical ventilation. What's really interesting about septic shock is a study that showed that 44% of survivors actually had cognitive scores less than 25% of typical population. It's shown that the younger you have septic shock, the higher you are for this risk of cognitive delays. Patients with septic shock also end up with diaphragm and skeletal muscle weakness, most likely from being mechanically intubated. They also have evidence of rhythm disturbances or dysrhythmias and decreased left ventricular function following an episode of sepsis, which is really critical because that decreased left ventricular function doesn't allow adequate blood flow to get to the body. It can really impair our physical function. So we all know that being in the hospital and being immobilized leads to weakness. We see muscle atrophy and loss of muscle mass occur within hours of critical illness, not days, not weeks, not months, but hours. Early mobilization in the ICU and early post-acute care management play critical roles in the recovery of muscle. The good news is that children aren't as high of a risk for critical illness myopathy and neuropathy, and they actually tend to recover quicker from weakness when compared to adults. So these statistics came from a report of a task force to develop expert opinions on treating COVID-19. They found that approximately 20 to 25% of hospitalized COVID-19 patients need care in the ICU for prolonged periods of time. This is weeks and weeks. Most of these patients were admitted to ICU for the hypoxemic respiratory failure and need for mechanical ventilation, and hypotension, requiring the vasopressor treatments in our inotropes. Most ICU admitted patients had multi-organ failure. 67% had ARDS, 29% had an acute kidney injury, 23% had a cardiac injury, and 29% have a liver dysfunction. They also found that the greatest change in physical function after diagnosis of acute respiratory failure was within the first 2 months after discharge. So this is critical for our outpatient and our rehab therapists, early intervention, to get in there and work with these patients after they're discharged. So now let's take a look at pediatric lung development. We'll specifically talk about the stages of development and implications of prematurity. So let's throw it back to fetal development and look at the stages of lung development. You can remember this by the acronym, every premature child takes air. So our first stage is embryonic, which occurs during gestational weeks 4 through 8. This is when our lung buds first start to form. This is followed by the pseudoglandular stage, weeks 5 through 17, where we see the tree-like branching occur in our lungs. One of the most important stages to point out is this clinicular phase from weeks 16 to 25. This is where our bronchioles are produced and we see our alveoli begin to develop. Why this is important is because we see our earliest premature babies right around the end of this phase. So if you think about a premature infant and their alveoli aren't developed and they get COVID-19, this is just a recipe for disaster. Next, we have our saccular phase, also called terminal saccular phase, but I always call it saccular phase even though it messes up our acronym. This occurs during weeks 24 through 36, and our alveolar ducts and our air sacs start to develop. Lastly, we have our alveolar phase, which occurs during weeks 36 into childhood. So we have a rapid growth of our alveoli all the way up to age 8. But we continue to see these alveoli change and our lung structures kind of get finalized all the way up until age of 20 to 23. And here we can get a nice visual of how these branches occur and how our alveoli develop. So let's chat about the impact of prematurity on lung function. If you're born premature, you lack surfactant that's needed to maintain a patent alveoli. If an alveoli is collapsed, you have impaired gas exchange, you can't deliver O2 to the body, and there's decreased lung expansion. This lactic surfactant is associated with increased respiratory distress, need for supplemental O2, or mechanical ventilation. If you're premature, you're at high risk for development of bronchopulmonary dysplasia, BPD, and scarring of the lungs. There are a lot of studies out there that have looked at lung function into childhood and adulthood following prematurity, and they've all found generally the same thing. You have diminished exercise capacity and agility, significant bronchoconstriction induced by exercise, there's presence of airway inflammation, and decreased VO2 max. So if you love lung volumes, you're going to love this slide. Let's dive into specific lung volume deficits seen after prematurity. So if we go into young adulthood following this period of prematurity, we see FVC, FEV1, and PEF values lower. So these are expiratory flows. We also have a lower total lung capacity, or TLC, but it's not really significant. In terms of working out, the workload max will be about 15% lower in these patients, and they'll also have a lower anaerobic threshold and heart rate max. What's most significant is these lower DLCO values. This is basically the total diffusion capacity of the alveolar capillary membrane of the lung, where a gas exchange occurs. This is vital for proper oxygen uptake during exercise. Without it, we can't exercise to our full capacity. This is thought to be low due to the immaturity and the underdevelopment of the lungs, in addition to a reduced number of alveoli. We also see thickened membranes in this population due to mechanical ventilation and excessive supplemental oxygen use. Also, our submaximal lung function is going to reach the danger zone of impaired lung function in elderly more quickly. There haven't been any studies to examine if training principles enhance lung function in this population, which would be a great thing to study. So lastly, we'll take a look at outcome measures and interventions. So infant standardized tests and measures that we can use to look at things like gross motor development. I highlighted a few because there are a ton of these out there. The first is the Alberta Infant Motor Scales, or the AIMS. And this is used on those less than 18 months old, but doesn't take into account for tone abnormalities, so those with hypotonia or hypertonia. Next is the TIMP, or the Test of Infant Motor Performance. It's used on those 34 weeks to 4 months of age and looks at things like postural and selective control of movement. It can be done by a variety of healthcare professionals. The GMA, or General Movement Assessment, is used via video. So you can examine those from birth to 20 weeks old to look for neurological issues that lead to developmental delays. So things like cramped synchronized movement. The Hammersmith Infant Neurological Exam, or the HINE. This one is used from 2 to 24 months old, and it can predict CP, or cerebral palsy. It examines things like behavior, gross motor milestones, tone, and reflexes. Moving on to toddler and child test and measures, I highlighted a few here. The first two, the Peabody and the BOT, assess gross and fine motor skills. I think it's good to point out that we might see fine motor skill deficits in these kids post-COVID, especially if we have lung and heart impact. So what I mean by that, if we're not getting proper oxygenation and blood flow to our muscles, our gross motor, our big muscle groups, are going to pick and take over that blood flow. So we might see weakness in the hands and things of that nature. The PD was developed to actually assess children with disabilities. And then we have the WeFM. So our rehab therapists might use this for our COVID-19 patients that have had prolonged hospital stays. What I want us to think about is how a PT and PTA can assess endurance from these measures. They don't directly assess endurance, but we can think about things like tummy time during the AIMS. Is a kid not holding his head up because he's weak, or is it because he doesn't have the endurance to do so and to maintain that head upright? So things like that we want to keep in mind, and we want to pair that with things like monitoring vital signs, monitoring for dyspnea, monitoring for diaphoresis or nasal flare and grunting, things of respiratory distress while we're giving these exams. Now we'll talk about child test and measures in terms of endurance and aerobic capacity. So the first test might bring back really bad memories of elementary school. It's the Presidential Fitness Test, or the Fitness Gram. This test looks at aerobic endurance, strength, flexibility, speed, and agility, which are all things that COVID-19 can impact. This test has things like sit-ups, a run-walk, pull-ups, V-sit, shuttle run in it. Next is the gold standard for cardiovascular and pulmonary PT. This is a 6-minute walk test. So this has really good valid research out there showing distance walk in relation to mortality and morbidity. So there are norms for children as young as 10 years old. And the reason I put an asterisk by that is if you really dive into the research, you'll see studies that actually use 6-minute walk tests for as young as 4-year-olds. But they're not really valid or reliable, and their distance walked is really based on how tall a patient is at that age. Next is the Progressive Aerobic Cardiovascular Endurance Run, or the PACER. When I heard about the title of this webinar series, I thought it was named after this and got really giddy, but that's a pediatric PT for you. So this is the beep test. This is where you have the 20-meter run, and it beeps and increases in speed each time. And this is a great test to look at aerobic endurance. And lastly, you can do a shuttle run, multi-stage runs where kids are running 10 meters, 20 meters, 30 meters at a time. Adolescent tests and measures for endurance are very similar to child, but there's 2 exceptions, the Bruce protocol and cycloergometry. With the Bruce protocol, this is a maximal exercise test that we commonly see in adults, but it's valid and reliable for ages 13 and up. With this test, you start somebody on a treadmill at a speed of 1.7 miles per hour with a 10% grade, and you gradually increase in increments up to 7 miles per hour with a 26% grade. Cycloergometry is very similar to the Bruce protocol, but it's not functional. So unless you're testing like Lance Armstrong Jr., then there's really no point in doing cycloergometry. So while we're giving these outcome measures, it's important to monitor your patient. You want to physically assess them and look for things like diaphoresis, increased breathing patterns and respiratory rate, see if they're pale, things like that. But the most important thing you can do to monitor your patient is to take their vital signs. #vitals are vital. So what I want to do is point out our trends in vital signs going from a premature infant all the way to an adolescent. So on this slide, we're seeing our vital sign averages for premature infants to 12-month-old. As you can tell, and again, these are resting. So as you can tell, our heart rate decreases as we get older. Our respiratory rate decreases. Our blood pressure increases, and our SpO2 should stay the same. And it's important to note, if you look at different references, some consider an SpO2 of a normal value to be greater than 95%. Okay? As long as we're above 90, that's within normal range. Just to point out a key thing, a lot of people ask, how do you remember these blood pressures? They're so different from adults. A newborn infant's blood pressure is exactly half of an adult's, if you want to remember it that way. When we look at our toddler and child vital signs, we see the same trends. From 2 years old to 12 years old, we see our heart rate start to decrease. We see our respiratory rate start to decrease. And we see our blood pressure start to increase. And again, our SpO2 stays the same. So as you can see, when you reach about 12 years old, your vital signs should be in line with those of an adult. Another way to assess the status of your patient is to use Borg scale ratings. So I use these a lot on patients that are on beta blockers where their heart rate's going to be blunted in response to exercise. So on the right, we have a modified Borg scale that goes from 0 to 10. A typical Borg scale goes from 6 to 20, and I find this one a little bit easier for pediatric patients to comprehend. So if I have patients do jumping jacks and I ask them afterwards to rate themselves on the scale, they might say, I'm a 1. They might say, I'm a 10, and then we might modify our treatment either way. There's some research out there that shows that if a patient rates themselves as a 5, that's equivalent to about 60% of a heart rate max. The chart on the left I use a lot for my younger patients who really can't give a reliable answer to the question of what are you on a scale of 0 to 10. So there are different kind of happy faces that show, like at the bottom, I'm watching TV and eating bonbons, I'm fine, versus a 10, which means they're dead. And keep in mind with pediatrics, a lot of times we don't get very valid responses to this. So assessing your patient's really the key to knowing how difficult or easy a task was for them. So this is an example of a dyspnea scale that Kahn developed. So in relation to how difficult or hard a task was, it's good to know how short of breath a patient is after an intervention. So this is an easy scale where someone can look at it and say, hey, I'm a 1, no trouble at all. Or I'm a 7, I feel like there's a rope wrapped around my lungs and I can't breathe. There's a variety of ways to look at shortness of breath and dyspnea. You can do a 0 to 4 scale with a patient if they're able to report that way. You can audibly hear how short of breath they are, and you can time how long it takes them to be not audibly short of breath. You can count the words a patient can say before they have to take another breath. And then you can have your patient count to 15 and see how many breaths they take within that time. Ideally, you should be able to go through a full breath cycle once while you're counting to 15. So not taking more than 1 breath during that duration. I wanted to go ahead and point out pain scales. It's not uncommon with somebody with a cardiovascular and pulmonary dysfunction to have pain, especially like rib and thoracic pain, when we're not getting great chest expansion and we kind of get stuck in those positions. So some infant pain scales I pointed out were the NIPS. So this looks at things like facial expression, breathing patterns, things like that. The FLAC, which is pretty commonly used. So this is used on children who can't communicate, and you give them points rated on a scale. The higher it is, the more severe the pain is. The CRIES, which is frequently used in the intensive care unit, it actually looks at how much oxygen a patient's on and their vital signs. Toddler child pain scales, we have the Wong-Baker-Faces pain scale, which are pretty common among pediatric therapists, and I'll show you an example of that in a second. If they're old enough and reliable, you can do a numeric ranking or a Likert scale, a VAS scale. So on a scale of 0 to 10, what's your pain level after this activity? You can also utilize the FLAC scale in this population as well. So here's an example of the Wong-Baker-Faces scale. So a child can pick, hey, I'm a 0, I'm not hurting at all, or if it's just the worst pain in the world, they need to go to the emergency room, they can pick the 10. So adolescent pain scales along the same lines, you can do a numeric ranking, a Likert scale, VAS scale of 0 to 10. You can use the Wong-Baker-Faces pain scale with them as well. You can also do a brief pain inventory, so you can have a body diagram and have them fill in where their pain is, how severe it is, how it impacts their function. And then there are things like the comfort scale. So if a patient's intubated, they can't communicate, you can use that to look at things like blood pressure. So if you're going from supine to sit and they have a drastic blood pressure change, that might indicate pain. Okay, so you can look at things like blood pressure, facial tension, crying, and muscle tone for this scale. So there is information regarding pediatrics in the physical activity guidelines for Americans. There's no info about children less than 3 years old, but it is suggested for ages 3 to 5 that there's structured play and movement throughout the day. For ages 6 to 17, we have more of a concrete guide. They recommend 60 minutes of moderate to vigorous activity daily. So that's about 50 to 85% of your heart rate max. This 60 minutes can be broken up into shorter bouts throughout the day. It's recommended that if you get more than 60 minutes, it actually has greater health benefits. But you should incorporate aerobic activity, muscle and bone strengthening 3 times a week. So what does that mean? What are examples of those activities? For aerobic conditioning, we want to do things like running, hopping, skipping, jump rope, swimming, dancing, bicycling. Muscle strengthening, you can do things like tug of war, climbing trees, playground equipment, using weight and resisted bands for children who are 9 years or older. For bone strengthening, we really look at impactful exercises, so running, jumping, basketball, tennis, and hopping. We want to think about creative ways to incorporate exercise into play activities for these younger children. So tag, red light, green light, Simon Says. All of these pediatric therapists are awesome at coming up with these interventions. Think about it in settings as well, like for school. For doing weight-bearing, muscle strengthening, bone strengthening, we might put somebody in a stander. Or we might have them go up and down ramps in their assisted devices, or up and down stairs. For EI, we might have our younger children pulling to stand at a couch and cruising. Outpatient, we might use just dance and activities like that, aquatic therapy. What we can do in all settings for kids who are old enough is really encourage sports, really encourage activity. So lastly, I'll leave us with some questions to ponder together. First and foremost, we want to know if asymptomatic, mild, and moderate cases of COVID-19 are going to lead to impaired cardiovascular, pulmonary, and musculoskeletal function. We can kind of guesstimate what the severe and critical cases might look like down the road, but we really have no idea what these kids are going to look like, and if they're more susceptible to getting COVID-19 in the future, etc. Is it safe and feasible for physical therapists to be treating these patients in all settings? This is a pretty common question, and the answer is if you have the correct PPE and the child is still contagious, then yes. There are a lot of facilities that are setting up a well side and a sick side to their clinic, especially in outpatient. The second question following this is how long are they contagious? How long will we have to take precautions in clinic with cleaning and PPE? We really don't know. Right now we're saying 2 weeks. But then again, we're still finding this disease and this disorder in fecal samples up to a month after being diagnosed. And also, is telehealth an option? There have been a lot of outpatient clinics and EI settings that are doing telehealth instead of actually going and seeing the patient, having physical contact with the patient. Well, this might be a great option. We have to think of things about like assessing our patient. And can we tell if somebody's in respiratory distress from a computer screen? Can we see if they're diaphoretic? Can we check their vital signs? Next, what are the most effective ways to treat patients from a physical therapy standpoint? Should we focus on endurance and aerobic activity? Should we look at things like if they're in heart failure, should we be doing more lower extremity resistive exercise? Things of that nature. Will our outcomes vary by age of patient? So are we going to see better outcomes in 1-year-olds versus 18-year-olds? Are we going to see very similar outcomes? We just don't know. And lastly, are we going to see developmental delays in infants with COVID-19? That's a great question. The hypothesis is yes, and they're going to need lots of physical therapy after COVID-19. So that ends our presentation. Thank you so much for listening. Here's my contact information in case you have any questions about this presentation. I'll be glad to answer them. And here are my references.